speak before you on one of the important topics of the modern medicine, hit early and hit hard. What is an effective glycemic control with the cardio-renal metabolic protection? So you all know that diabetes is ever-growing epidemic across the globe. So I need not tell you the numbers. So the diabetic numbers are increasing in a astronomical proportion all over the world in general, but in India in particular. But we people, diabetics, are totally different from the Western population by these measures. We have the increased abdominal adiposity and the visceral fat, and increased ethnic and the genetic susceptibility. Our adiponectin levels are lowered. That could be the important reason for causation of your diabetes and ischemic heart disease. And our inflammatory markers, the vascular inflammatory markers like high sensitive CRP are very high in our Indian population. We are having the lower BMI threshold for the diabetes. That is the reason the BMI was normal. BMI for Indians is the 23 versus the 25 for the Western population. We are having the lower age threshold for the CV disease. We are getting the CV diseases even at an younger age group, and also for the lean population. We have the increased insulin levels, that is the hyperinsulinemia. That could be the important reason for your metabolic syndrome. And we also have the faster onset of the beta cell dysfunction. That is the reason we people, our people, they need insulin therapy much early when compared to the Caucasians. And there is a diabetic dyslipidemia in the form of increased triglycerides, reduced HDL, and increased or the normal LDL. There is an increased consumption of the unhealthy foods, street foods, etc., high calorie dense foods. And important thing is faster progression from the pre-diabetes to the diabetes. So in India right now, we are having nearly 12 crores of the diabetics and nearly the 13 to 14 crores of the pre-diabetics. And the conversion rate is almost 80% versus 14.4% in the Western population. So all these measures are clearly says that the Indian diabetes is totally different from the Western population. We know much about the diabetes management, but still the diabetes in India is more challenging. And if you see the recent ICMR India study, so a lot of the people are diabetic, hypertensive, dyslipidemia, obesity. But the interesting point here is 64% of the Indian type 2 diabetic patients, they do not attain the HbA1c target of less than 7%. So your goal of HbA1c in all our diabetic individuals somewhere between 6.5 to 7. But very, very few people are reaching this target. So that is the reason we have to improve our management of the diabetes. We have to identify the diabetes at early time. We have to give the good combination therapy, and also we have to start insulin as and when required so that we can reach the HbA1c target of 6.5 or the 7. We all know that the long-term complications of the diabetes are very, very high and it's a life-threatening, lot of morbidity and the mortality. And not only the diabetic retinopathy, but also the early onset of the cataracts, glaucoma, etc. Not only your nephropathy as far as the renal complications is concerned, but the ascending urinary tract infections, pyelonephritis, etc. Not only ischemic heart disease, but also the heart failures, arrhythmias, or cardiomyopathies. As far as the foot is concerned, the foot ulcers is the very important cause for your amputations. And not only the foot ulcers, both the peripheral neuropathies, either vascular or the neurological, are combined. And also the neurogenic foods are very important, your Charcot's foods. And the pregnancy complicating diabetes is also very common in our population because of the late marriages, because of the obesity at the time of the pregnancy, because of the strong family history. So while dealing a case of the diabetes in our Indian population, so we have to stress on all these things. So what is more important and distressing is reduce life expectancy in people with the diabetes. See, there is a age gap of between 2.5 to 12.9 years, nearly 13 years lifespan has reduced depending on the age at onset of the diabetes and also its comorbidities. So younger the diabetes, higher the age life expectancy, reduced life expectancy will be seen when the diabetes we are getting at an younger age group. But unfortunately, we are seeing the type 2 diabetes at the age of 15, 16, 17, 20, etc. So what are the challenges posed by the type 2 diabetes in Indian population? The poor compliance. Even though they are educated, even though they are urban, the diabetic individuals in Indians are poor compliance with the poor therapeutic adherence. And achieving the target and the durable glycemic control is very, very poor. I told you earlier that the A1C for most of our Indian diabetics, average A1C is 9.3. And also we are not having any durable glycemic control. And obviously the complications we are getting much early and also very troublesome. And there are many more challenges we are posed by the type 2 diabetes, maybe the different barriers, maybe the physician barriers or the patient barriers as far as the insulin therapy is concerned. These are the complication burden we are seeing in Indian population. The neuropathy is the highest with about nearly 25%. Cardiovascular next to the neuropathy about the 24%. nephropathy nearly the 21% and retinopathy 16%. See, these are all will reduce the quality of the life. So what is more important than diabetes is we have to improve the quality of the life. Unfortunately, because of these complications in the diabetes we are getting in Indian population, so our lifespan is reducing. Whatever the cardiovascular burden of the newly type 2 diabetes diagnosed patients in India, nearly 40% were classified as the high risk. You please see these figures. 40% as the high risk and about 60% are very high risk. 40 plus 60, 100%. So that means all the diabetes diagnosed in Indian population, they are either high risk or very high risk. That means diabetes means a vascular disease. Diabetes means myocardial infarction equivalent. And this clearly shows that this is a multinational study. Unni Krishnan, Sahai from north, south, east, west, etc. Pan-Indian study. It shows that the same thing. So 40% were high risk and about 60% were very high risk. See, while treating the diabetes, we have to respect the pipes, we have to respect the pumps, we have to respect the filters. Pipes means vasculopathy, pumps means your left ventricular, whether systolic pumping or the diastolic pumping. Unfortunately, most of the diabetics, they will land up with either diastolic dysfunction or your systolic dysfunction. And of course, the CKD, your proteinuria and elevated urea creatinine levels are very important. So to give a good quality of the life, we have to respect the pipes, pumps and filters. Diabetes up to 5 times increased risk of the heart failure in the type 2 diabetes, and nearly the 58% of the patients with type 2 diabetes, they develop the CKD and both are interrelated. So 20% of the hypertension people will also have the CKD and nearly 25 to 30% of the CKD population will land up with the heart failure. So it's most like a interlinked cause and effect. And CKD acts as an amplifier for the CV risk. So all the CKD population, they die in the hands of the cardiologist rather than the nephrologist because CKD acts as an amplifier of the CV risk. What are all the complications you know of heart, whether it is heart failure or ischemic heart disease, or unstable angina, or arrhythmias, or hyperkalemia, etc., they will be multiplied in the presence of your CKD. So always the diabetes and CKD means almost they're going to die within a cardiac event. CKD is not a silent killer. It's a very big disease. It's a global pandemic. Unfortunately, the CKD of stage 1 and 2 and also the 3 are asymptomatic. Even 50% of the CKD 4 stage, they are also asymptomatic like your type 2 diabetes. So it is our duty as a good physician, you should identify the CKD at an early age group in all the diabetic individuals. So don't be happy with your fasting and the postprandial blood sugars always. Please get the urea, creatinine, electrolytes, or urinary albumin creatinine ratio, UACR, in most of our diabetic individuals, and also the retina examination, because retinopathy and the nephropathy are very close friends, they are interlinked. So what we see that stage 4 diabetes, kidney disease or CKD caused by the diabetes is also called as a DKD, that is a diabetic kidney disease. The tip of the iceberg is the stage 5. Lot of the people, they are living with the 1, 2, 3 and 4. When they reach the stage of the 5, the only treatment of choice is your renal replacement therapy, either the dialysis or the transplantation, which is not what useful or not possible for each and every patient of the CKD stage 5. And fortunately, most of the people in Andhra Pradesh, they are getting the treatment from the Arogyasri as far as the dialysis is concerned. But I doubt the quality of the dialysis, these Arogyasri people are getting it. But you also know that a lot of the complications in stage 5, as far as sodium is concerned, potassium is concerned, phosphorus, calcium, your osteoporosis, anemia, erythropoietin deficiency, etc. So it's a multifactorial to reach to give a good prescription for all our CKD population in the stage 5. CKD alone is a strong risk factor for the CVD. That also I told you, independent of the diabetes, hypertension, or any other conventional CVD risk factors. CKD itself is a big risk factor for the CVD. So protect your kidneys, save your heart. So kidney dysfunction increases the risk of the cardiovascular diseases significantly. Proteinuria. See, always the CKD means not only the elevated creatinine levels, but also the proteinuria. So one is the structural abnormality, another one is the functional abnormality. So the proteinuria because of your glomerular dysfunction. It is an independent effect of the albuminuria on the risk of both CVD and all-cause mortality at all levels of the GFR. And increased urinary albumin predicts both the CV and all-cause mortality. So the proteinuria nowadays we are considered it is not only as a marker for your nephropathy, but also a marker for your vasculopathy. So proteinuria means more and more chances of having the cardiovascular diseases. So protect your kidney, save your heart, get your blood pressure checked. This is a very, very important. So the more the blood pressure, the more the complications and the risks. So the diabetes and the blood pressure is the deadly duo. In all the diabetic individuals, you have to check the blood pressure. Not only checking the blood pressure, you have to keep the blood pressure as close to the normal as possible. Maybe below the 130 by 85, maybe 120 by 80, or maybe 120 by 75 in some of the individuals, so that we can protect your kidneys and the heart. Treatment of the CKD reduce the CVD. Albuminuria is a better predictor of the renal and the cardiovascular events than the blood pressure alone. So we have to treat the albuminuria also, as long as your blood sugars and the blood pressures. Reducing the proteinuria is more renal and cardioprotective than the lowering the blood pressure alone, and identification of the CKD can improve the CV outcomes. So how to handle the CKD? So this is my favorite slide. ABCD is very important for all the diabetic individuals, whether they are CKD or non-CKD. A stands for A1C to reach your 6.5. B stands for blood pressure. C stands for your LDL cholesterol. It's less than 100 is wrong, less than 50 or less than 70. So now our goal of LDL is less than the 70, and all the diabetic individuals less than the 55 when the fellows are with a very high cardiovascular risk. So drugs, avoid the nephrotoxicity drugs. It's always advisable to avoid your NSAIDs and avoid your aminoglycosides or avoid your contrast materials, etc. And also most important is the moderate in the protein or high in the protein. Unfortunately, the protein requirement for all our Indians is 1 gram per kg body weight, but our diets are reducing the are rich with the low protein and high carbohydrate and high saturated fat. So as far as the diet is concerned, we have to reduce the trans fats, we have to reduce the saturated fats, we have to reduce the simple sugars, and also we have to improve the protein, either the vegetable protein or the non-vegetarian protein. And vegetable protein is 1000 times better than the non-vegetarian protein as far as the CKD is concerned. So concentrate on the sodium and potassium, maintain the sodium somewhere between 135 and potassium around 3.5 to 4, and phosphorus is very important. So fluid management is very important in all the CKD population. So the more the fluid intake, obviously the more the chances of left ventricular failure or pulmonary edema. Calcium is very important because osteoporosis or renal osteodystrophy are very, very common in the CKD population. Now move on to the other metabolic abnormalities, the obesity. It is the 21st century pandemic. It is now the single greatest contributor to the chronic disease. Diabetes means diabetes plus obesity. And obesity will soon become the leading cause of the death. I hope that already it has become the leading cause of the death as far as the Indians are concerned. No one is normal weight right now. Most of our people sitting here are either overweight or the obesity. You all know the complications of the obesity, maybe the diabetes or the pancreatitis or coronary artery disease, stroke or fatty liver, etc. These are all very common in the obesity population. Not only these things, carcinomas are also very common in the obesity population. Now the incidence of the carcinomas are also increasing in the society. So you have to respect a lot to the adipose tissue. It itself is an endocrine organ. See the cytokines releasing from your adipose tissue. Your adiponectin levels or the leptin levels or TNF or interleukins or CRP, etc., leading to the hypertension, dyslipidemia, type 2 diabetes, thrombosis, atherosclerosis, and vascular inflammation. So that is the reason we have to reduce our adipose tissue. Unfortunately, all of us are having the more and more adipose tissue, especially in our abdomen. So that is the metabolically active adipose tissue. So to keep your adipose tissue under the normal contents, you should maintain your waist circumference less than 36 in the males and less than 32 in the females. That is 90 centimeters in the males and 80 centimeters in the females. You have a lot of the benefits. If you lose the 10% of the weight loss, all the benefits you will have from the mortality to the several things. We have to respect a lot to the glucagon-like peptide, popularly known as GLP-1. So this is a very, very important incretin hormone released from the small intestines, from the jejunum and the ileum. It enhances the insulin release in the presence of the glucose is the most important point as far as the GLP is concerned. When you have the hyperglycemia, that stimulates to release the insulin, beta cells. If you have the euglycemia, it won't stimulate the insulin beta cells to release more and more insulin. So it is glucose dependent. That is the reason you don't get the hypoglycemia when you use the GLP-1 receptors alone, unless you combine with the sulfonylureas or the insulin. It reduces the glucagon release from the alpha cells. It's the only molecule which acts on the alpha cells. All these years, pancreas means we respect only the beta cells. Now we have to respect the alpha cells also, because alpha cells secrete the glucagon, which is antagonist to your insulin, The more glucagon means more and more hyperglycemia. So hyperglucagonemia means hyperglycemia because of increased hepatic glucose output. So in all the diabetic individuals, we need reduced reaction of the alpha cells. So that could be done with your glucagon like peptide 1 therapy. That's GLP-1 therapy. These are the only molecule which act on the alpha cells. It slows the gastric emptying. It reduces the food intake by acting on your satiety center. So you have the beautiful actions of the GLP-1. So we have to respect the GLP-1. And now the people who can afford, we have the oral and also we have the parenteral GLP-1 receptor agonist drugs. This is an important slide, shows you the cardiometabolic risk starts early in the natural history of the type 2 diabetes. You all know that type 2 diabetes occurs when hyperinsulinemia gives way to your insulin resistance. So usually in the early stages, those people will have insulin resistance. To tackle the insulin resistance, our pancreas starts releasing more and more insulin, that is hyperinsulinemia. But a stage will come where the insulin resistance will not be controlled with your hyperinsulinemia, and then hyperinsulinemia will come down and there will be the beta cell fatigue and there will be the insulin deficiency. So hyperinsulinemia is the root cause for your metabolic syndrome. You know by this time what you mean by the metabolic syndrome, a cluster of the 4 diseases, your diabetes, hypertension, obesity and dyslipidemia. For the root cause is the hyperinsulinemia. So already the hyperinsulinemia, till you get the diabetes, that means you have lot of the cardiometabolic and kidney risk factors. Whom to screen for the cardiorenal metabolic risk status in the adults? All the people with obese individuals, record the BMI, maintain at 23, record the waist circumference, and all I told you the numbers, 90 and the 80, and metabolic syndrome components, liver fibrosis, your fatty liver. So this is the most commonest ultrasound finding whenever you send anyone to the ultrasound abdomen right now, it is the fatty liver. So the fatty liver, definitely it's a risk for the ischemic heart disease. Fatty liver is a risk for your cholelithiasis. Fatty liver is a risk for early malignancies, and fatty liver is a risk for many diseases. So we have to respect the fatty liver. We have to reduce it only by means of your lifestyle measures. Of course, your saroglitazar will also work on this drug, but that is not feasible for each and every patient because of the cost factor. USCR and the serum creatinine, they are very important. Subclinical heart failure, again heart failure, the important cause of the heart failure in India are the 3 diseases. One is ischemic heart disease, second one is diabetes, the third one is the hypertension. But unfortunately, both the diabetes and hypertension people will have ischemic heart disease. So heart failure is so common. It is it is not that easy to diagnose the heart failure in the early stages. But if you diagnose the heart failure in the early stages, definitely can give good quality of the life and you can postpone the death also. Otherwise, established heart failure means more and more hospitalizations and early death. Understanding of the cardiometabolic interaction led to the evolution in the treatment of the type 2 diabetes management towards the organocentric therapy. So earlier, way back in 2009, the concept of the diabetes management is glucose-centric. So control fasting, control PP, control HbA1c, the lower the better. That was the theme in those days. And later, by 2015, so control the HbA1c, but also not at the cost of hypoglycemia or not at the cost of weight gain. So no weight gain, no hypoglycemia, along with your HbA1c and fasting and the postprandial. But later, in 2018, our concept is cardiorenal events reduction. And finally, in today, 2025, our concept is all these things, control HbA1c, control fasting, PP, cardiorenal, and also quality of the life. So that is our glycemic pentad at this juncture. Glycemic pentad means one is fasting, second one is PP, third one is HbA1c, and fourth one is GV, that is glycemic variability, and the fifth one and most important one is the quality of the life. So how to keep the quality of the life for all of the diabetic individuals, so that is the motto in 2025 ADA. Burden of CKM is increasing worldwide in general and in India in particular. Fine, another 2 minutes. 1 in 3 patients with the type 2 diabetes have the cardiovascular disease. CVD is the leading cause of the death in the type 2 diabetes. So adiposity is the same thing, the obesity. So definitely will cause a lot of the things. See the stages of the CKM. So the stage 0 is the most important one. These are high risk individuals. Here the dietary approach and your exercise is very important. And stage 1, your overweight or the obesity reduction is important. And stage 2, metabolic risk factors. So you have to control the diabetes, hypertension, etc. And finally, these people will have subclinical atherosclerotic cardiovascular disease or subclinical heart failure. And finally, atrial fibrillation, peripheral arterial disease, etc. So these are the targets in reducing the CKM management: blood pressure, blood lipids, glucose, insulin resistance, and inflammations. So guideline recommendations. So control the glycemic, control the weight, control the heart, and then use the GLP-1 receptor agonists or gliptins. So the 2025 ADA guidelines for the management of type 2 diabetes, it is individualized. So when the fellows are at risk of getting the atherosclerotic cardiovascular disease, use either GLP-1 receptor agonists or the SGLT2 inhibitors. When the fellow is at risk of the heart failure, use the SGLT inhibitors. When the fellow is at risk of the CKD, use the SGLT inhibitors. When the fellow is overweight, use the GLP-1 receptor agonists or the SGLT2 inhibitors. When the fellow is in the fatty liver, so use the drugs like the dual GIP and the GLP-1 receptor agonist, that is tirzepatide. So the Monjaro, that is very much available in India. Now it is a game changer in the management of the obesity. Now we are using it at the stage of 2.5 milligrams once in a week for the first four weeks. Later you can update the dose to the 5 milligrams, that is the tirzepatide doses. This is the KDIGO guidelines on the management of the CKD. So the lifestyle measures are very important. SGLT inhibitor, metformin, RAS inhibitors, and the statins. What are the actions of the GLP-1 receptors in the type 2 diabetes? So it's a homogeneous octet. You know all these causes hyperglycemia, your liver, your muscle, adipose tissue, etc. So that's how you get the hyperglycemia. So this is the very important slide. GLP-1 receptor agonists. So they not only act on the brain to reduce your appetite, they act on the liver, they act on the kidney, they act on the vessels, they reduce the plaque and also the heart. What else you require in a diabetic individual? Suppose if they can afford, so definitely the GLP-1 receptor agonists are the beautiful agents to tackle all these things. So the obesity is very important. They also reduce the EAT, that is the epicardial adipose tissue, GLP-1 receptor agonists. You have the oral semaglutide, that is a beautiful drug. They improve the GFR, and also it has the pioneer study, that is upon oral semaglutide. They cause 21% reduction in the MACE. SGLT inhibitors, cardioprotect, you all know how they act it, because what are all the glucose is there filtered, that is again reabsorbed from the proximal convoluted tubule. Here you have the two receptors, SGLT2 and SGLT1. SGLT is responsible for 90% reabsorption when you are using these SGLT inhibitors like your DAPA or EMPA. So definitely they prevent the reabsorption. So causes diuresis, causes natriuresis, causes glucosuria, and also advantage is the uricosuria. So definitely they reduce the preload and reduce the afterload. That is how it is cardiac friendly and the renal friendly and vascular friendly. So these are all the pleiotropic effects, not only on the kidneys, but also the heart and the vessels. So these are the guidelines. This is the combination. So the dynamic duo. So these are the complementary actions of these two drugs. So EMPA is a game changer with the linagliptin. So they reduce the body weight, reduce the BP, reduce the uric acid. You have the CV benefits, you have the renal benefits, you have the no additional hypoglycemic risk. Even you combine these things. By combining these two, genital infections are so less. Unfortunately, when you are using alone SGLT inhibitor, more the chance of UT and the GI or genital infections like your monilial. But when combined with the linagliptin, if you see the MPAREG outcome trial, outscores over your canvas trial or the declarative trial as far as the canagliptin or the dapagliflozin is concerned. So these are the molecular comparisons. So DAPA is 1200 fold, whereas the empagliflozin is 2500 fold as far as your SGLT2 inhibition is concerned. So the benefits: cardioprotective, renoprotective, and pleiotropic. So you can use all these conditions. So they also increases your life expectancy by 4.5 years. So the target organ protection can be seen. So what are the priorities? Good glycemic control is important. Address the comorbidities and address the complications. So thank you very much for your patient hearing.